Familial Mediterranean fever, FMF, is an inherited autoinflammatory disorder predominantly affecting individuals of Mediterranean descent, such as those from Armenian, Turkish, Arab, and Jewish populations. It is characterized by recurrent episodes of fever and serositis, including inflammation of the peritoneum, pleura, or synovium, which can result in abdominal pain, pleuritic chest pain, or arthritis. Pathogenesis. Genetics. FMF is an autosomal recessive disease caused by mutations in the MEFV gene on chromosome 16, which encodes for the protein pyrin, marinostrin. Pyrin plays a role in the regulation of the inflammatory response through the inflammasome, specifically in the control of interleukin 1 beta, IL-1 beta production. Mutations in MEFV disrupt this control, leading to increased IL-1 beta production and systemic inflammation. Inflammasome activation. Pyrin mutations result in dysregulated inflammasome activation, leading to recurrent episodes of inflammation. The result is the production of pro-inflammatory cytokines, causing the characteristic symptoms of FMF. Clinical features: recurrent fever. Spontaneous, self-limited episodes of fever, typically lasting 1 to 3 days, are a hallmark of FMF. These febrile attacks can be accompanied by serositis. Serositis, peritonitis, presents as acute abdominal pain, often mimicking surgical conditions like appendicitis or peritonitis. Pleuritis causes sharp pleuritic chest pain, which can be mistaken for pleurisy or pneumonia. Synovitis, arthritis, especially affecting large joints like the knees, ankles, and hips, can occur during attacks. Erysipelas-like erythema, some patients develop a red, painful skin rash, often found on the lower limbs. Complications. Amyloidosis. The most serious long-term complication of untreated FMF is secondary amyloidosis, AA type, which can lead to kidney damage and renal failure. It results from chronic elevation of serum amyloid A protein, a byproduct of ongoing inflammation. Diagnosis. Clinical criteria. Diagnosis is mainly clinical, relying on recurrent episodes of fever, serositis, and a typical ethnic background. The Tel-Hashomer criteria are often used for diagnosis, considering symptoms, family history, and response to colchicine. Genetic testing. Identifying mutations in the MEFV gene supports the diagnosis, though genetic testing is not always definitive due to variable expressivity and mutation types. Laboratory findings. During attacks, patients may exhibit elevated acute phase reactants, such as ESR, CRP, and leukocytosis. These markers typically normalize between attacks. Treatment. Colchicine. The cornerstone of FMF management is daily colchicine, which effectively prevents attacks and reduces the risk of amyloidosis. It is thought to work by inhibiting microtubule formation and decreasing neutrophil activity, thus reducing inflammation. Most patients respond well to 1 to 2 milligrams per day. Biologics. In colchicine-resistant cases or those with severe symptoms, IL-1 inhibitors, e.g. anakinra, canakinumab, can be effective by directly targeting the IL-1 pathway involved in the inflammatory response. Lifestyle management. Regular monitoring for amyloidosis and adherence to medication is crucial. Avoidance of known triggers for attacks, such as physical stress or infections, may help reduce flare-ups. Prognosis. With proper management, most patients with FMF can lead a normal life with a significant reduction in the frequency and severity of attacks. Early and consistent use of colchicine is key to preventing long-term complications like amyloidosis. Summary. FMF is a genetically inherited autoinflammatory disease characterized by recurrent fever and serositis. Advances in understanding its genetic basis have improved diagnosis and allowed for targeted therapy, primarily through colchicine and biologics. Early diagnosis and treatment are crucial to avoid complications like amyloidosis, which can severely affect the patient's quality of life. Classification criteria for familial Mediterranean fever, FMF, are primarily used for diagnosis and research purposes, helping to standardize the identification of patients with FMF. One of the most widely used criteria sets is the Tel-Hashomer criteria. Here's a breakdown. Tel-Hashomer criteria for FMF. The Tel-Hashomer criteria classify FMF into major and minor criteria. A diagnosis is made based on the presence of specific combinations of these criteria. Major criteria. 1. Recurrent febrile episodes, a 38° C accompanied by serositis, which includes peritonitis, abdominal pain, pleuritis, chest pain, synovitis, arthritis. 2. Amyloidosis of AA type without a known cause. 3. Positive response to continuous colchicine therapy, characterized by a significant reduction in the frequency or severity of attacks. Minor criteria. 1. Recurrent febrile episodes. 2. Erysipelas-like erythema, which is a red, painful rash. 3. FMF family history. Diagnosis. The diagnosis of FMF according to the Tel-Hashomer criteria is made when a patient has 2 major criteria, or 1 major plus 2 minor criteria. Additional criteria for research. Some research studies and clinical guidelines may refer to other criteria, such as Livnet criteria, another set of criteria that is more detailed and provides different categories for clinical manifestations. Genetic testing. While not part of the original Tel-Hashomer criteria, genetic testing for mutations in the MEFV gene has become an important component in diagnosing FMF. The presence of certain mutations can support a clinical diagnosis, though it may not be definitive on its own due to variable expression of the disease. Summary. The Tel-Hashomer criteria remain the most recognized clinical framework for diagnosing FMF, focusing on typical symptoms, response to colchicine, and family history. However, the combination of clinical criteria and genetic testing offers a more comprehensive approach, especially in atypical cases or when colchicine response is uncertain. Genetic analysis plays a significant role in the diagnosis of familial Mediterranean fever, FMF. While clinical criteria remain crucial for diagnosis, genetic testing for mutations in the MEFV gene offers additional insights, especially in atypical presentations or for confirming diagnoses. Here's how genetic analysis contributes to the diagnosis of FMF. 1. Confirmatory diagnosis. Identification of MEFV mutations. FMF is caused by mutations in the MEFV gene located on chromosome 16, which encodes the protein pyrin. Genetic analysis can identify these mutations, supporting the diagnosis when clinical symptoms are present. Common mutations include M694V, M680I, V726A, and E148Q. Homozygous versus heterozygous mutations. Homozygous mutations, e.g. M694V, M694V, are often associated with more severe disease and an earlier onset. Heterozygous or compound heterozygous mutations, e.g. M694V's V726A, may have a milder or variable clinical presentation. Identifying the specific mutations can thus help assess the likely disease severity and guide management decisions. 2. Diagnosis in atypical cases. Variable clinical presentation. Some patients with FMF may not present with typical symptoms like recurrent fevers or serositis. Genetic analysis can be especially helpful in these cases, providing evidence of FMF when clinical features alone are insufficient. Overlap with other conditions. Symptoms of FMF can overlap with other autoinflammatory or autoimmune diseases, e.g., systemic juvenile idiopathic arthritis, adult onset Still's disease. Genetic testing can help differentiate FMF from these conditions, clarifying the diagnosis. 3. Prenatal and family testing. Family history of FMF. Since FMF is an autosomal recessive condition, siblings and relatives of an affected individual may be carriers or affected themselves. Genetic testing can identify carriers among family members, especially in populations with a high prevalence of FMF, such as those of Mediterranean descent. Prenatal testing. In certain cases, genetic analysis may be considered for prenatal testing, especially if both parents are known carriers of pathogenic MEFV mutations. 4.4. Prediction of colchicine responsiveness. While most patients with FMF respond to colchicine, certain mutations like homozygous M694V are associated with a higher risk of more severe disease and amyloidosis. Identifying these mutations can prompt earlier and more aggressive treatment to prevent complications. This genetic information can guide treatment decisions, such as the need for higher doses of colchicine or the early introduction of IL-1 inhibitors in cases resistant to colchicine. 5. Role in research and population screening. Genetic analysis contributes to a better understanding of FMF's pathogenesis and helps identify genotype-phenotype correlations. For example, studying the relationship between specific mutations and clinical severity helps refine treatment approaches. In populations with a high prevalence of FMF, genetic screening can help identify asymptomatic carriers and better define the mutation spectrum in specific ethnic groups, aiding in community health planning. Limitations of genetic testing in FMF diagnosis: incomplete penetrance and variability. The presence of a mutation in the MFV gene does not always mean that an individual will develop symptoms. Some individuals may carry mutations without showing clinical signs of FMF, making it necessary to interpret genetic results in the context of clinical symptoms. Genetic variability. There are many different mutations in the MFV gene, and not all are associated with symptomatic FMF. Some mutations may be benign or have only a weak association with the disease, which can complicate the interpretation of results. Summary: genetic analysis of the MFV gene is a valuable tool in diagnosing FMF, particularly for confirming cases, understanding the severity of disease, and differentiating FMF from other conditions. However, it should be used as a complement to clinical criteria rather than as a standalone diagnostic test, given the variable expression and incomplete penetrance of MFV mutations. Combining genetic data with clinical evaluation ensures a more accurate diagnosis and tailored management of FMF. Yes, it is possible to diagnose a case of familial Mediterranean fever, FMF, even if genetic testing for MFV mutations is negative. While genetic testing is a useful tool for supporting a diagnosis, the diagnosis of FMF is ultimately clinical, based on the characteristic presentation and response to treatment. Here are some key considerations when diagnosing FMF in the context of a negative genetic test. 1. Clinical criteria remain primary. Tel-Hashomer criteria and Livney criteria are widely accepted clinical frameworks for diagnosing FMF and do not require a positive genetic test for diagnosis. A diagnosis can be made based on a history of recurrent episodes of fever, serositis, such as abdominal pain, pleuritis, or arthritis, and a positive response to colchicine therapy. If these criteria are met, a negative genetic test does not rule out FMF. Genetic testing limitations. Genetic variability. More than 300 mutations have been identified in the MFV gene, but genetic tests may only screen for a limited panel of the most common mutations. A negative test might occur if a patient carries a rare mutation that is not included in the test panel. Incomplete penetrance. Not all individuals with MFV mutations exhibit symptoms, and similarly, some patients without detectable mutations can still display the clinical features of FMF. Unknown genetic variants. Some cases of FMF may involve mutations in regions of the MFV gene that are not yet fully understood, or in other genes that influence the inflammatory process, making diagnosis based on genetics alone incomplete. 3. Diagnosis based on clinical judgment. Positive response to colchicine. One of the hallmarks of FMF is a significant improvement in the frequency or severity of attacks when treated with colchicine. If a patient shows a typical clinical presentation of FMF and has a marked response to colchicine, this is strong supporting evidence for FMF, even in the absence of genetic confirmation. Ethnic background and family history. FMF is more common in individuals of Mediterranean descent, e.g., Jewish, Arab, Armenian, and Turkish populations. A typical clinical presentation in someone from a high-risk ethnic group or with a family history of FMF further supports a clinical diagnosis. Number 4. Differential diagnosis. It's important to rule out other autoinflammatory or autoimmune conditions that can mimic FMF symptoms, such as systemic juvenile idiopathic arthritis, SJIA, adult-onset Still's disease, AOSD, other periodic fever syndromes like TRAPS, tumor necrosis factor receptor associated periodic syndrome, or CAPS, cryopyrin associated periodic syndromes. A thorough evaluation and exclusion of these conditions can reinforce the clinical suspicion of FMF. 5. Amyloidosis risk. If a clinical diagnosis of FMF is made, patients should still be monitored for complications like secondary amyloidosis, especially if they present with persistent inflammation markers like elevated serum amyloid A, SAA levels. Early treatment with colchicine is critical for preventing amyloidosis, regardless of genetic test results. Summary: a diagnosis of FMF can be made in the absence of a positive genetic test if the clinical presentation aligns with the characteristic symptoms of FMF and other similar conditions are ruled out. A positive response to colchicine is a key diagnostic indicator in such cases. Thus, the clinician's judgment, guided by the patient's symptoms and treatment response, remains the cornerstone of diagnosing FMF. The treatment of familial Mediterranean fever, FMF, has evolved, incorporating both traditional approaches like colchicine and newer therapies such as biologics. For patients who do not respond to colchicine or have limited access to biologics, there are alternative options. Here's an updated overview of the current guidelines for treating FMF, including the use of biologics and potential alternatives. 1. Colchicine, first line therapy. Dosage. Colchicine remains the cornerstone of FMF management for preventing acute attacks and reducing the risk of amyloidosis, secondary amyloidosis type AA. Typical dosing for adults ranges from 1 to 2 milligrams per day, adjusted based on response and tolerance. Pediatric dosing is calculated based on body weight. The dose can be titrated up to a maximum of 3 milligrams per day in adults if necessary and tolerated. Effectiveness. Most patients experience a significant reduction in the frequency and severity of attacks with colchicine. Colchicine is also highly effective in preventing amyloidosis. Side effects. Gastrointestinal side effects like diarrhea can limit colchicine's use in some patients. Dose adjustments or splitting doses throughout the day can help manage these side effects. 2. Colchicine-resistant FMF, CRFMF. Colchicine-resistant FMF is defined as having persistent attacks despite the use of maximum tolerated doses of colchicine or ongoing inflammation as indicated by elevated acute phase reactants, e.g. CRP-ESR, despite therapy. Patients with CRFMF are candidates for biologic therapy. 3. Biologic therapy, second-line treatment. Biologics are used in patients who are colchicine-resistant, intolerant, or at high risk of complications like amyloidosis. They primarily target the IL-1 pathway, which plays a central role in the inflammatory process of FMF. IL-1 inhibitors. Anakinra, a daily subcutaneous injection of an IL-1 receptor antagonist. It is effective in reducing attack frequency and controlling inflammation in CRFMF. Canakinumab, a monoclonal antibody that targets IL-1B, given as a subcutaneous injection every 4 to 8 weeks. It is effective in reducing attack frequency and controlling systemic inflammation. Rilonacept, an IL-1 trap that can also be used, though it is less commonly utilized compared to anakinra and canakinumab. Considerations for IL-1 inhibitors. IL-1 inhibitors are highly effective but may be costly and less accessible in some regions. Monitoring for potential side effects such as injection site reactions, infections, and changes in lipid levels is essential. 4. Alternatives to biologics. For patients who do not have access to biologics due to cost or availability, alternative approaches may include nonsteroidal anti-inflammatory drugs, NSAIDs. NSAIDs can help manage symptoms during acute attacks, such as fever and pain. However, they do not prevent attacks or amyloidosis. NSAIDs like ibuprofen or naproxen can be used as adjunctive therapy to colchicine for symptomatic relief. Corticosteroids, short courses of low-dose prednisone, may be used during severe attacks, particularly if NSAIDs are not effective. However, long-term use should be avoided due to the risk of side effects. Corticosteroids are not suitable as a primary treatment due to their inability to prevent amyloidosis and their side effect profile. DMARDs, disease-modifying anti-rheumatic drugs, methotrexate and azathioprine have been used anecdotally in colchicine-resistant cases or where biologics are not available. They may help control inflammation, but are generally less effective than biologics. Hydroxychloroquine can also be considered for its anti-inflammatory effects, although evidence is limited in FMF. Thalidomide. In some studies, thalidomide has been shown to reduce inflammation in patients with CRFMF. However, it has significant side effects, including teratogenicity and neuropathy, which limit its use. 5. Monitoring and long-term management. Regular monitoring. Monitor patients for symptoms, attack frequency, and laboratory markers of inflammation, e.g. CRP, ESR, serum amyloid A. Regular follow-up is essential to assess treatment response and adjust therapy as needed. Renal function monitoring. Given the risk of amyloidosis, monitoring renal function with serum creatinine and urine protein levels is crucial, especially in patients with persistent inflammation. Patient education. Educate patients about adherence to colchicine therapy, possible side effects, and the importance of routine follow-up to prevent complications like amyloidosis. 6. Special considerations. Pregnancy. Colchicine can be used during pregnancy as it is generally considered safe. However, monitoring for side effects and adjusting dosages may be necessary. Children. Colchicine dosing in children should be weight-based, and biologics like anakinra or canakinumab may be used if colchicine is ineffective or poorly tolerated. Summary of current treatment approach. 1. First line, colchicine adjusted to maximum tolerated dose. 2. Second line, IL-1 inhibitors, anakinra, canakinumab for colchicine-resistant cases. 3. Alternatives if biologics unavailable, NSAIDs, short-term corticosteroids, DMARDs like methotrexate or thalidomide. 4. Regular monitoring, focused on attack frequency, inflammation markers, and preventing amyloidosis. With this approach, most patients with FMF can achieve effective control of symptoms and minimize the risk of long-term complications like amyloidosis, improving their quality of life. Yes, IL-6 inhibitors, such as tocilizumab, can play a role in the management of familial Mediterranean fever, FMF, in certain cases, especially when IL-1 inhibitors are not available, ineffective, or not tolerated. While IL-6 inhibitors are not the primary choice for treating FMF, they can be considered as an alternative option due to their anti-inflammatory effects. Here's an overview of the potential role of IL-6 inhibitors in FMF. Part 1. Rationale for using IL-6 inhibitors. Role of IL-6 in inflammation. IL-6 is a pro-inflammatory cytokine involved in the acute phase response and systemic inflammation. Elevated IL-6 levels are often seen during inflammatory episodes in FMF, contributing to symptoms like fever and elevated acute phase reactants, e.g., CRP. Mechanism of IL-6 inhibitors. IL-6 inhibitors, like tocilizumab, work by blocking the IL-6 receptor, thereby reducing the effects of IL-6-mediated inflammation. This can help control systemic inflammation and the associated symptoms in patients with FMF. 2. When to consider IL-6 inhibitors in FMF. Lack of access to IL-1 inhibitors. In regions where IL-1 inhibitors, e.g. anakinra, canakinumab, are unavailable or cost-prohibitive, IL-6 inhibitors can be an alternative, though evidence for their use is more limited. Inadequate response to IL-1 inhibitors. Some patients may not achieve full control of symptoms with IL-1 inhibitors or may experience side effects. In such cases, switching to an IL-6 inhibitor could be considered. Persistent inflammation. For patients who continue to exhibit elevated inflammation markers, such as CRP and serum amyloid A, despite colchicine and IL-1 blockade, IL-6 inhibitors may help in controlling the residual inflammation and preventing complications like amyloidosis. Evidence for IL-6 inhibitors in FMF, case reports and small studies. The use of tocilizumab in FMF has been reported in some case studies and small series, where it was used either as monotherapy or in combination with colchicine. These reports suggest that tocilizumab can reduce the frequency of attacks and control inflammation markers in colchicine-resistant patients. Chronic inflammation control. IL-6 inhibitors may be particularly beneficial in controlling chronic low-grade inflammation between attacks, helping to reduce the risk of amyloidosis progression. Dosage and administration. Tocilizumab is usually administered as a subcutaneous injection, 162 milligrams every 1 to 2 weeks, or as an intravenous infusion, typically 8 milligrams per kilograms every 4 weeks for adults. The dosing may vary depending on the severity of inflammation and the patient's response. Monitoring requirements. Regular monitoring for potential side effects like liver enzyme elevation, lipid profile changes, and risk of infections is necessary, similar to other biologic therapies. 5. Potential limitations of IL-6 inhibitors. Limited specific evidence in FMF. Compared to IL-1 inhibitors, the evidence supporting the use of IL-6 inhibitors specifically for FMF is more limited. The majority of guidelines recommend IL-1 blockade as the preferred option due to its central role in the pathogenesis of FMF. Side effects. Tocilizumab can cause side effects such as elevated liver enzymes, changes in lipid levels, and increased risk of infections, requiring careful monitoring during therapy. Cost and availability. Although tocilizumab may be used as an alternative to IL-1 inhibitors, it might still be expensive and not always available in certain regions. Summary: IL-6 inhibitors. In the management of familial Mediterranean fever, FMF, especially in colchicine-resistant cases, FMF, or where standard treatments like IL-1 inhibitors are unavailable or ineffective, other biologic therapies and targeted synthetic DMARDs, SDMARDs, may play a role. Here is an overview of their potential roles and applications. 1. TNF inhibitors. TNF inhibitors, such as etanercept, infliximab, and adalimumab, target the tumor necrosis factor, TNF, a cytokine involved in inflammation. Their use in FMF is generally less common compared to IL-1 inhibitors, but they have been considered in certain situations. When to use? TNF inhibitors may be considered when both colchicine and IL-1 inhibitors are ineffective or unavailable. They can help in reducing inflammation and controlling symptoms in patients with FMF, particularly in cases with persistent arthritis or other inflammatory manifestations. Evidence. The use of TNF inhibitors in FMF is supported primarily by case reports and small studies rather than large trials. Some patients have shown a reduction in inflammatory markers and attack frequency when treated with TNF inhibitors. Limitations. TNF inhibitors are generally not considered the first choice due to limited evidence of their effectiveness, specifically in FMF compared to IL-1 inhibitors. Additionally, they come with risks like increased susceptibility to infections and the potential for inducing paradoxical inflammation. 2. IL-12/23 inhibitors, e.g., ustekinumab. Ustekinumab, which targets both IL-12 and IL-23, has been primarily used in diseases like psoriasis and psoriatic arthritis, but has a potential role in autoinflammatory diseases like FMF. When to use? It may be considered in cases where other biologics have failed or are not available, particularly in patients who exhibit significant cutaneous manifestations alongside systemic inflammation. Evidence. Its use in FMF is not well established, and evidence is mainly anecdotal or from off-label use. Ustekinumab could be considered in a trial-and-error approach in resistant cases where conventional options are exhausted. 3. IL-17 inhibitors, e.g., secukinumab. Secukinumab, which targets IL-17A, is another biologic that has shown promise in inflammatory conditions like ankylosing spondylitis and psoriatic arthritis. When to use? There is limited data on the use of IL-17 inhibitors in FMF. It might be considered in selected cases of FMF with significant musculoskeletal symptoms or as a potential option when IL-1 and TNF inhibitors are not suitable. Evidence. The role of IL-17 inhibitors in FMF remains experimental and is generally not a standard approach due to a lack of robust clinical evidence. 4. JAK inhibitors, SMARDs. JAK inhibitors, a class of targeted synthetic DMARDs, have gained attention for their ability to modulate cytokine signaling involved in inflammation. Some examples include tofacitinib, baricitinib, and upadacitinib. Mechanism. JAK inhibitors block the Janus kinase pathway, which is involved in the signaling of various pro-inflammatory cytokines, such as IL-6, IFN-Guang, and others. By modulating this pathway, JAK inhibitors can reduce systemic inflammation. When to use? JAK inhibitors might be considered for FMF patients who do not respond to colchicine and have no access to biologics. They can be an option for managing chronic inflammation, particularly if the patient presents with arthritis or other inflammatory symptoms. Evidence. While there is no direct, large-scale evidence for the use of JAK inhibitors in FMF, their effectiveness in other autoinflammatory and autoimmune conditions suggests a potential role. Case reports have shown that JAK inhibitors can be effective in reducing inflammation and attack frequency in autoinflammatory syndromes. 5. B-cell depletion therapy, e.g. rituximab. Rituximab, an anti-CD20 monoclonal antibody, is not typically used for FMF, but may be considered in specific clinical scenarios. When to use? It might be considered in FMF patients with overlapping autoimmune diseases like systemic lupus erythematosus, SLE, or in cases where other treatments have failed. Evidence. Its use in FMF is anecdotal, with little evidence directly supporting its efficacy. Rituximab is more commonly reserved for conditions with a predominant autoimmune component rather than purely autoinflammatory diseases like FMF. Summary of roles for other biologics and SMARDs in FMF. 1. TNF inhibitors. Useful in cases with persistent arthritis or inflammation when IL-1 inhibitors are unavailable. Limited evidence and potential for paradoxical effects. 2. IL-12/23 and IL-17 inhibitors. Potential experimental options when standard treatments fail, but with limited evidence in FMF. 3. JAK inhibitors, emerging as a possible option due to their broad anti-inflammatory effects, but require further study in FMF. 4. Rituximab, not a typical choice for FMF, considered only in specific cases with overlapping autoimmune features. Overall approach. The management of FMF with these alternatives depends on individual patient needs, availability of therapies, and a careful assessment of risks versus benefits. IL-1 inhibitors remain the most effective biologic therapy for colchicine-resistant FMF, but in their absence, a trial of TNF inhibitors, JAK inhibitors, or other biologics might be warranted, with close monitoring of clinical response and side effects. The prognosis of familial Mediterranean fever, FMF, can be quite variable depending on the severity of the disease, adherence to treatment, and the presence of complications like amyloidosis. Generally, with appropriate and consistent management, patients with FMF can lead a normal life. Here's an overview of the prognosis and considerations regarding the duration of treatment. 1. Prognosis of FMF. Long-term outlook. For most patients, FMF is a lifelong condition characterized by recurrent episodes of fever and serositis, e.g., peritonitis, pleuritis, arthritis. However, with proper treatment, the frequency and severity of these attacks can be significantly reduced. Impact of colchicine. The introduction of colchicine has dramatically improved the prognosis of FMF. Regular colchicine use can prevent acute attacks, significantly reduce the risk of developing secondary amyloidosis, a severe complication that can lead to kidney failure. Decrease inflammation and reduce levels of acute phase reactants, e.g. CRP, ESR. Amyloidosis risk. The most serious long-term complication of untreated or poorly controlled FMF is the development of AA, secondary amyloidosis, which can cause kidney damage and potentially end-stage renal disease. Colchicine has been proven to prevent amyloidosis effectively, and patients with good compliance generally have a much better prognosis. Quality of life. With effective treatment, most patients can maintain a good quality of life, continue their education, and have normal social and occupational functioning. 2. Duration of treatment. Lifelong treatment. In general, FMF treatment with colchicine is considered lifelong. This is because the underlying genetic defect that causes FMF does not change over time, and symptoms may return if treatment is stopped. Here's why lifelong therapy is typically recommended. Symptom control. Continuous colchicine use is essential to maintain remission and control recurrent attacks. Amyloidosis prevention. Lifelong colchicine therapy is crucial for preventing amyloidosis, as stopping treatment can increase the risk of developing this complication, even if the patient is asymptomatic for a period. Considerations for adjusting therapy. Dose adjustments. In certain cases, the dose of colchicine might be adjusted over time, depending on symptom control, side effects, and patient tolerance. Pediatric patients might have their dose adjusted as they grow. Monitoring during pregnancy. Colchicine is generally safe in pregnancy, but doses may need to be adjusted, and close monitoring is advised. Rare cases of reduced therapy. There may be rare cases where therapy could be reconsidered or paused. Asymptomatic cases. Some patients who remain symptom-free for many years might consider a trial of dose reduction under close medical supervision. However, this is generally not recommended because of the ongoing risk of amyloidosis. Mild disease variants. Patients with milder forms of FMF, especially those with atypical mutations or low-risk genetic profiles, might be considered for reduced doses, but this decision should be made with caution and close monitoring. 3. Patient adherence and education. Importance of adherence. Ensuring patients understand the importance of lifelong treatment, even when they are asymptomatic, is crucial. Non-adherence to colchicine is one of the major risk factors for developing amyloidosis and experiencing recurrent attacks. Regular follow-up. Regular follow-up with a healthcare provider is important to monitor for symptoms, side effects, and any complications of FMF or its treatment. Summary. Prognosis. With appropriate and consistent treatment, most patients with FMF have a favorable prognosis and can live a normal life. Treatment duration. Colchicine therapy is generally lifelong to control symptoms and prevent complications, especially amyloidosis. Monitoring. Adjustments in dosing might be needed over time, but stopping treatment is not generally advised due to the risks involved. By maintaining adherence to colchicine and undergoing regular medical follow-ups, patients with FMF can manage their condition effectively and minimize the risks associated with the disease.